Hi everyone, it's Catherine here at RNAO, and I think we're going to get started. It's now 12 o'clock, and we want to thank you for attending today's webinar presentation. We're using the WebEx platform today, and we hope that you can hear us clearly and see our slides that we're going to be presenting. We do also have a chat box option, and ask that you use the All Participants option so that everyone is able to see the questions. And our plan will be to address your questions at the end of our presentation. So this is our presentation on our recently released breastfeeding best practice guideline, breastfeeding, promoting and supporting the initiation, exclusivity and continuation of breastfeeding for newborns, infants, and young children, the third edition. So my name is Catherine Wallace. I'm the Guideline Development Lead here at RNAO with background in nursing and in midwifery, and so I was really excited to work on this guideline. And I'm joined today, unfortunately, not by Glynis, who you see on the photo. Glynis is off sick with her daughter, and we hope that she's doing okay. Instead, we're joined by Erica D'Souza. Did you want to say hi?
Hi, everyone.
Great. And also with two members from our panel, starting with our co-chair, Dr. Sonia Semnek. Sonia, did you want to introduce yourself, please?
Yeah, hi, everybody. I'm an associate professor at the England School of Nursing and a nurse scientist at the McGill University Health Centre in Montreal, Canada. In my previous career, I was a clinical nurse specialist and lactation consultant for many years in a large tertiary hospital. I completed a PhD in 2005 on factors influencing the duration of exclusive breastfeeding in first-time mothers, and since then I've developed a research program on the implementation of evidence-based practices related to breastfeeding promotion and support, including implementation of the Baby-Friendly Hospital Initiative. So I was really delighted and thrilled to be invited to co-chair this important breastfeeding practice guideline.
Thanks, Sonia. And Stephanie.
Shikoli, my name is Stephanie. I'm Oneida Nation. I'm the Community Breastfeeding Coordinator over on the Six Nations of the Grand River. I'm an Aboriginal midwife and an IBCLC.
Wonderful, and we're delighted to have both Sonia and Stephanie join us today as co-facilitators. I do want to acknowledge that this guideline is the result of hard work from the whole RNAO team. I'm just representing myself and Erica today, the team. So I want to acknowledge the research associates that worked on the guideline, coordinator, our senior leadership who provide then guidance to us throughout the development of this guideline, as well as other colleagues who support the implementation of this guideline. Really is a team effort, and we're very excited to have this guideline now published. Our objectives for today, we want to highlight the practice, education, and organization and system policy recommendations, as well as some other related resources within the guideline. We'll talk a little bit about guideline development process, and then we also want to talk about some other resources that are relevant to the Breastfeeding Best Practice Guideline, or the BPG as we like to call them, just to make you aware of some other resources we have available that can be a help as far as implementation and further understanding. So who is RNAO, just briefly? So the Registered Nurses Association of Ontario is the professional association for registered nurses, nurse practitioners, and nursing students here in the province of Ontario. And we've been the professional association since 1925 with over 42,000 members, our highest to date. We have two main mandates. One, to influence and promote healthy public policy, as well as clinical excellence. And our Best Practice Guidelines program is our signature program here at RNAO. So if you're looking for this guideline, you'll find it on the rnao.ca website. I've just highlighted a few points here to make you aware. Should you have any questions regarding this guideline or any other guideline, we have the Contact Us button there near the top right of the slide. This guideline is available as a free download, as well as can be purchased as a hard copy. On the bottom of this web page then, the same web page then, are some related files for this best practice guideline. So a bibliography and the quality appraisal scores. So this is relating specifically to those studies that we used in our discussion of evidence to be able to show you which studies we used and the quality appraisal of each of those studies. We also have a file that indicates from our expert panel declaration of competing interests. This is part of a rigorous guideline development process that we declare with transparency any panel conflicts of interest throughout the development of the guideline. And lastly, we have a file on the search strategy that we use then to find the studies to inform our recommendations. You'll also see on this same web page the link for the online course on breastfeeding e-learning. So this is available on elearning.rnao.ca. So on a separate web page, you'll find this, all of our e-learning courses. And under the tab of Women and Children, then you will find the Breastfeeding eLearn. Now, this course is based on the second edition of the BPG. At this time at RNAO, all of our e-learning courses are being moved to a different platform. We anticipate that work will be done by the end of this year, and then at that point we'll look at all of our e-learns and determine which one to prioritize next. Certainly it is our hope that this one soon will be updated to reflect the new content of the revised breastfeeding guideline. But I know many have used this e-learn, perhaps in part to inform their knowledge, as well as if they are applying for IBCLC and needing those hours. So I hope that you will find this helpful. But just to be aware, it is based on the previous edition of this best practice guideline at this time. I want to just say some words of thanks before we get into the guideline. As indicated, it's a full team here at RNAO that contributes to the guideline. And in addition, we have an expert panel. Again, we're delighted to have Sonia with us today. Our other co-chair was Dr. Cindy Lee Dennis. We very much enjoyed having Cindy Lee as part of this process. And important to us as we create a guideline that's evidence-based to have nurses who are PhD prepared, who are able then to support us in the discussion of that evidence, the interpretation, to be able to ensure that we are producing a high-quality document. I want to also acknowledge the other members of our expert panel, other nurses, as well as Stephanie, an Aboriginal midwife, as well as we had a family doctor. And then we also had some members from key stakeholders, including BFI Strategy for Ontario, La Leche League, INFACT, and IPVAN. So an excellent panel that supported us to be able to create the guideline that we have. And our thanks to all of them for the hard work that they did. They were very much engaged in this work. It was very important to them that we create a high-quality guideline that would meet the needs of persons in this province and elsewhere. That's just a picture of all of us when we were here at the RNAO office for our visits, for our meetings. In addition, we want to thank the 66 stakeholder reviewers. And we just listed all of them here. Please know that I've just included their designation and not all of the rest of their other degrees. Please have a look at the guideline for that. But our stakeholders provide a key feedback in the guideline and also provided us with feedback on the evaluation measures. So we just want to thank all of them for that work. In terms of guidelines, you may be aware that there is a tool called the AGREE tool that helps us to define whether a guideline is of high quality, and included in that quality criteria are stakeholder involvement. This guideline is intended for nurses, for members of the interprofessional team, as well as peer advocates. So it's important as we look at the members of the expert panel as well as stakeholders to ensure that we have that representation. So as you look through these names, and I wanted you to look at it and just be able to see that we do have strong representation from all three of those different groups. It's also our intention that this guideline be applicable across health sectors. So again, as you look at the list of stakeholders, to see that we have representation from individuals working in acute care, in public health, community health, in academic settings, etc. Again, that's important to have those different perspectives represented on the guidelines. Additionally important in terms of health sectors that we have representation in urban as well as rural settings, again, because when we think about access to breastfeeding services and different needs of individuals, then that can be influenced by the accessibility to those services. Finally, our stakeholders provide important feedback in terms of ensuring that we have all the best resources, Mostly, though, they help us to know whether the guideline is feasible in clinical practice. If it's not feasible in clinical practice, it's a guideline that won't be used much, and our intention is not only to develop a resource that someone can read and learn from, but perhaps more importantly, a resource that someone can use in their clinical practice. So the feasibility component is really key. So again, we thank everyone for their involvement in this guideline. With 66 stakeholder reviewers, it tells us this is an important topic to many of you, and again, our guideline is strengthened by that feedback. So the purpose of this guideline, we wanted to provide evidence to enhance the quality of nurses, members of the interprofessional team, and peer advocates in their practice in breastfeeding, initiation, exclusivity, and continuation across the perinatal period. So beginning with what interventions or assessments can we do prenatally up to the postpartum period and extending up to 2 years of age. Our initial focus was going to be on continuation. As we looked at the evidence, we found that the majority of the studies focus more on initiation and exclusivity. So you'll see that we do have some interventions that focus on continuation, but the majority are on initiation and exclusivity. It's important to recognize, too, that the purpose of a guideline is not to replace a textbook, but rather than to provide information from evidence then that helps to support informed decision-making. So the scope of the guideline, from our previous 2 guideline additions, includes then strategies to support continuation. So if you're familiar with our first 2 additions, they focused on initiation and exclusivity, particularly in the first 48 hours and early post-discharge. This guideline, we wanted to extend our focus and the scope to up to 2 years. And we wanted it to be applicable to all healthcare settings that were relevant for this population. And if you're looking for more details on the scope, on the intended audience, again, nurses, interprofessional team, and peer advocates, and the guiding principles, you can find that in the guideline. 30 pages. So our recommendations, and we're going to talk about those next then, are in 3 different categories. The majority, 12 of them, are the practice recommendations. So what is it that we want for the nurse or the other healthcare provider or peer to do as far as demonstrating and implementing best practices in breastfeeding? Secondly, a recommendation in education. So what is it that I need to know as far as knowledge and skills in order to successfully implement those practice recommendations? And then the last category, organization and policy recommendations. So what do I need from my organization or the broader healthcare system in order to successfully implement those practice recommendations? Last few slides before we get into the specific recommendations, so just how to read the recommendations. And this is a change if you haven't seen this guideline but are familiar with some of our older guidelines. You'll see that there have been some changes in the presentation and some of the categories that are included in the discussions of evidence. So we always include the research question. The research question then is what guided then the development of the recommendations, and the research question then links back to the purpose and the scope of the guideline. We then have the recommendation statement box. The recommendation is an action-orientated statement, and then we include the level of evidence for summary, and we have a table in the guideline that lists the different levels of evidence and what types of study design that's referring to, as well as the quality of evidence for summary. And so in doing this and capturing this in the recommendation box, then it means we don't have to have it in the evidence summary discussion, and makes it perhaps a little bit easier to read the evidence summary. If you're wondering then where would I know then which studies are the high and which one are the moderate, looking at the example on the slide, that's when you would refer back then to that related document that's available on the web page that lists all of the studies that were used to inform the discussions of evidence. So we have 5 different sections that make up the discussion of evidence. The evidence summary are the key findings from the evidence, and we asked our stakeholders and our panel, was there sufficient evidence then to support that recommendation statement, and if there were any concerns, then we tweaked the language in that to make sure that it was fully comprehensive and representative of the findings. Our next section is on benefits and harms. This is looking at, is there any additional benefits or any harms that we learned from the evidence that would promote or deter from a person's well-being, and important to emphasize those. And then values and preferences really is asking the perspective of the recipient of the care, in this case the person who is breastfeeding or planning to breastfeed. Are there any values, priorities that they have from the evidence that are important for us to consider? In the case that we didn't find any in the evidence, then we asked our expert panel, really asking them, okay, why is this particular recommendation important? What are the underlying values? Why is this important for us to continue to include this in the guidelines? Then our next section is on practice notes. These are pragmatic information from the evidence. So important again to remember that a guideline is not a textbook, so we're not giving you the step-by-step how-tos as far as clinical care, but rather just what can we glean from the evidence. If there were studies that included a section called implications for clinical practice, we often use some of that content, but it was just what were the key findings that we could use at the point of care that would be helpful that are based on the evidence. And then the last section on supporting resources created in table format listed any relevant resources. As many of you will know, there are many resources available in the area of breastfeeding, so we chose to focus on those that were evidence-based, that were consistent with the recommendation, that were non-sponsor content. So if you opened a resource and it included purchasing something, then we didn't include that. We didn't feel that was really aligned with an evidence-based guideline. And that was published in the last 5 years. And you'll see for many of them we do have links to those resources. So we encourage you to look at the downloadable version of the guideline, where then you can access these resources to see then more information relevant to the specific recommendation. I'm going to hand it over now to Sonia and Stephanie, who are going to walk us through then the 16 recommendations that make up this best practice guideline, and they're going to be talking about some of those different components, the evidence summaries, as well as some of the other parts that make up the discussion of evidence. Thanks, Sonia.
Hi, everybody. Just to mention, in the interest of time, we're not going to have time to go into too much detail with each of the recommendations, so we're going to just touch on them, read out the recommendations, and highlight some key points. All the underlying evidence behind these recommendations and much more details about these recommendations are available for you in the documents. So to begin, our first recommendation was to assess the breastfeeding process using validated and reliable tools during pregnancy and at key stages of lactation. Now, assessment in pregnancy begins with exploring the person's breastfeeding intentions, beliefs, knowledge, confidence levels, and support levels so that we can enhance their capacity to initiate exclusive breastfeeding and sustain exclusive and continued breastfeeding. And other key time points for a comprehensive breastfeeding assessment, according to the literature, are during the first 24 hours and prior to postpartum discharge, when we know is a very critical time for initiating successful breastfeeding. During that transition from stage 1 to stage 2, lactogenesis in the first couple of days postpartum, during that first week when the breastfeeding person may be experiencing engorgement or some continued problems from initiation. And of course, to continue the assessment process after milk supply has been established to support continued breastfeeding success. Next slide. There are many other tools aside from the ones in this box that might be used. Oops, sorry. Yeah. Okay. So we've included in the recommendation some main tools that we found in the literature that are used to conduct breastfeeding assessments, or some standardized tools. We're aware that there are other tools that are being used, but the idea is that using a comprehensive standardized tool to assess breastfeeding makes it more likely that breastfeeding issues will be picked up and that breastfeeding persons will have access to the support that they need that's tailored to their specific needs. So here we talked about the latch tool, the H&H lactation scale, the breastfeeding self-efficacy scale. There might be others. The importance is to use a standardized comprehensive tool for assessments. Next slide. The next recommendation is to facilitate skin-to-skin contact immediately following birth or once the infant is clinically stable. It's well recognized that the facilitating skin-to-skin supports breastfeeding initiation, exclusivity, reduces potential problems with breastfeeding initiation, enhances maternal confidence. The research does vary according to when skin-to-skin should start exactly or how long it needs to last to influence breastfeeding exclusivity and longer-term outcomes. But the consensus from the literature really is that all babies should have the opportunity to go to skin as soon as possible after birth and to remain there until breastfeeding is initiated. Next slide. Which brings us to the next recommendation, which I think is one of the most important recommendations, which is to support the early initiation of breastfeeding, ideally within 1 hour of childbirth or once the breastfeeding diet is clinically stable, through multi-component perinatal interventions, beginning with prenatal education and really following up with immediate postpartum bedside assistance. This is essentially step 5 of the Baby-Friendly Hospital Initiative. There's very strong evidence linking early initiation, immediate initiation in the first hour after birth with longer-term breastfeeding outcomes. And really preparing a mother for early initiation begins with education prenatally of the breastfeeding person and the support network. But a big focus of this recommendation is really on the hands-on, immediate postpartum guidance and support that's needed to initiate successful lactation and feeding, within an hour or so after delivery. And, the literature really shows now that the best way to do this is by allowing the infant to follow his spontaneous and innate behaviors that begin when a baby is put skin-to-skin after birth. Next slide.
Okay, so this is Stephanie. Now, moving on to recommendation 2.3, we support the breastfeeding diet to achieve effective positioning, latch, and milk transfer. And this is done best at the bedside, talking moms through the process. It also includes prenatal education and emotional follow-up, because sometimes moms feel with all the interventions at birth that she might feel a little downtrodden and needs some more support. She needs to be told on how good that the things that she is doing. We also need to know causes of nipple pain. So that's what's on the right-hand side there. We need to know the basics about candida infection and psoriasis of the nipple, and eczema, and the herpes simplex virus. Next slide. So this includes an appendix on these breastfeeding challenges and recurring nipple pain and some suggested interventions that are backed up in the literature. Next slide. So 2.4, we support the breastfeeding diet to achieve, got to change my sheet. We support responsive cue-based breastfeeding through strategies such as education and promotion and recognition of the needs of the breastfeeding person. So we need to have consistent information across the board between nurses and between shifts, between midwives. And we need to recognize the breastfeeding person's needs and the demands on the person with unrestricted breastfeeding. And these benefits can include, because you're supporting the mom, you're supporting the physiology of supply and demand. It enables the breast milk supply to align with the changes with the baby as it grows, and responds to breast fullness to self-manage supply and comfort. Next slide. Oh, I love that picture. Teach hand expression. And so the benefits of teaching hand expression to all breastfeeding persons, it really does help to achieve exclusivity, because moms can feel that she is doing something, and she can, as my client say, she can see that her breasts are working. It's a tool that can support their preferences and needs. And it's a mechanism to enhance breast milk production, which is wonderfully found in the literature.
Oh, sorry.
That's okay. You're enjoying it too much there, Sonia.
So recommendation 2.6 is to implement individualized breastfeeding self-efficacy interventions throughout the perinatal periods to enhance breastfeeding confidence. including one-on-one counseling prior to discharge from the hospital setting and follow-up post-discharge. We have quite a large body of evidence now which shows a mother's confidence or her self-efficacy, beliefs in her ability to breastfeed is the strongest predictor of rates of exclusive breastfeeding and continued breastfeeding. And we now have some good ways to measure confidence, like the breastfeeding self-efficacy scale. So the idea is it really should be routine practice now that we pay attention to levels of breastfeeding self-efficacy when we are providing prenatal education on breastfeeding and preparing the breastfeeding person and family for the breastfeeding trajectory. And then also when helping a person to breastfeed and helping manage them with their breastfeeding issues, that we're purposely using interventions that help boost breastfeeding confidence, especially around perceptions of insufficient milk supply. And, interventions to enhance breastfeeding efficacy can be done through education, through particular attention to providing support and encouragement for ensuring that everything is being done to facilitate early breastfeeding experiences by addressing individualized concerns and providing continued follow-up. Next slide. And this is very tightly linked with the recommendation to provide individualized assistance to support or enhance breast milk production where appropriate. Given that perceived or actual low milk supply remains the number one reason that breastfeeding is stopped earlier than intended, or that breastfeeding exclusivity is influenced, we need to make sure that we're giving the support that is needed in situations where milk supply can be at risk. Whether or not this is an infant who is ill or in the neonatal intensive care unit or otherwise separated from the parents, or if breastfeeding is compromised due to maternal problems like sore nipples, over-engorgement, breast surgery. In the appendixes of the document, tables 9 and 10 provide a good list of different situations where milk production that may need to be supported. Next slide. Which then leads to the next recommendation, which is to provide individualized assistance to support or enhance breast milk volume when needed. This recommendation recognizes that there are many situations where breast milk volume may need to be increased. It doesn't mean that this is a recommendation that needs to be applied to all women, but we know that interventions to enhance breastfeeding supply, to enhance milk supply, may include either skilled interventions to correct breastfeeding problems and to enhance feeding frequencies. It could be assistance with milk expression and guided assistance with proper expression and how to enhance milk supply when you are separated from your infant, or even the use of galactagogues in some cases. Recognizing that in most situations, responsive, cue-based breastfeeding, effective positioning, getting breastfeeding off to a good start, whatever we do to stimulate milk transfer will stimulate sufficient milk supply in most women. Next. Okay, so recommendation.
Sorry,
Hello?
go ahead.
So recommendation 2.8 is to provide ongoing proactive breastfeeding support services. This of course is to help encourage longer durations of exclusive and continued breastfeeding. And to do that, proactive support over the whole breastfeeding trajectory is needed. We tend to concentrate our breastfeeding support services in the very early postpartum period, which is helpful for successful initiation, but we realize has not had a big impact on continued exclusivity or longer term durations. The evidence shows that regular contacts during the first week or months, which is really the critical period for the establishment of breastfeeding, makes a big difference in longer term breastfeeding outcomes. The research shows that, contact between 4 to 8 contacts over the first couple of months seems to be make a significant difference. These kinds of contacts can be done by phone or during regularly planned postnatal or well baby visits with healthcare professionals. So we really have to pay attention to ensuring that we are providing breastfeeding assessments, support, encouragement during all those planned activities that we have with mothers in the postnatal period. Breastfeeding peer support programs is also a very effective way of providing proactive, individualized support for breastfeeding. So we need to think about how to enhance the access of mothers to breastfeeding community resources, where they will be getting regular contacts and proactive support for breastfeeding. Next slide. Let's bring us back to Stephanie.
Yes, thank you, Sonia. So recommendation 2.9 is to facilitate informed decision-making regarding pacifier use. I know in the lactation world this can be a difficult discussion for some, but there's actually limited evidence to indicate that there's significant impact on partial or exclusive breastfeeding rates to 4 months if they're used after breastfeeding is established and only when the breastfeeding persons are highly motivated. So to support the decision making, we need to explain to parents that there is limited evidence and the impact on short-term breastfeeding challenges hasn't yet been determined, and also that frequent and prolonged use of pacifiers can potentiate breastfeeding challenges with nipple confusion or insufficient milk supply. So in the practice notes section, it includes divergent perspectives from leading North American health authorities. Health Canada and the American Academy of Pediatrics indicate delaying pacifier use until breastfeeding is well established, if at all, and WHO does not recommend pacifiers. Of note, too, we need to discuss that the protective agents of breastfeeding against SIDS, maybe it has something to do with pacifier use as well. So informed choice, we talk on both sides, the pros and the cons, and it facilitates the decision making for the parent. Okay, recommendation 2.10, provide breastfeeding education throughout the perinatal period and as long as breastfeeding continues. So this is across a variety of settings through diverse approaches, including those tailored to the needs of vulnerable populations. So provide breastfeeding education as long as the breastfeeding continues, because we understand about parents needing to know the growth spurt times and introduction of solid foods and weaning questions as well. We can do it in a variety of settings, one-on-one or group discussions. And we also need to tailor the education to the needs of the population. So breastfeeding education was strongly shown in the literature to increase rates of exclusivity and continuation, because knowledge and knowing that someone's there for support is very helpful to the breastfeeding parent. Next slide.
So, go ahead. Sorry, Stephanie. Recommendation 2.11 includes family members in the breastfeeding education support. And I personally have a lot of fathers and grandmas that attend the breastfeeding classes that I do, and the moms say that it works. Their support in the family and with their breastfeeding. So it makes breastfeeding more exclusive for a longer time, which is wonderful. So when we include the family, it recognizes the influence of socio-cultural environment that may be a facilitator or barrier to those decisions. And support from partners and grandmothers is also shown in literature to be associated with higher levels of personal satisfaction for the breastfeeding person and a positive attitude towards breastfeeding. So recommendation 3.1, now we're getting to sort of more broader policy recommendations, is to provide continuing education that incorporates theoretical knowledge and practical skills to the interprofessional team, to nurses, and to peers that incorporate, and to peer support persons as well. I think we're all aware that healthcare professional knowledge and skills related to breastfeeding is critical for supporting breastfeeding. And the literature confirms that continuing education programs really provide, to those who work with breastfeeding families, really has a significant impact on breastfeeding support practices. This recommendation is in line with the BFHI step number 2, and there's actually a big body of literature now coming out of the Baby Friendly Hospital Initiative implementation research that shows the huge impact that the 20-hour WHO course has on breastfeeding professionals. I think this recommendation is a bit of a no-brainer, but it's an important reminder that institutions and governments really need to invest in breastfeeding education and support if they want to improve their breastfeeding outcomes. And to be most effective, education needs to be combined, with both theoretical training as well as more practical hands-on training, mentorship, and guidance at the bedside. Next slide. So, recommendation 4 is to consider integrating lactation consultants in the provision of care to the breastfeeding diet throughout the perinatal period in health services and local communities. There's enough evidence that shows that having access to specialized breastfeeding resources, such as lactation consultants, does make a big difference in breastfeeding rates, and it really does help to supplement care in busy healthcare settings where not everybody might have access to specialized supports. We do have to recognize that the literature in this area is a bit mixed because the studies have looked at different types of specialized resources. There's quite a bit of research on certified lactation consultants, but there's also breastfeeding counselors, different kinds of breastfeeding resource persons. So we have the recommendation phrased as consider having access to, consider engaging lactation consultants, being aware that not everybody has access to lactation consultants in their community, but certainly having the presence of persons with extra breastfeeding expertise has been shown to impact on breastfeeding outcomes. And the kinds of lactation consultant services, can be from education, counseling, providing support and education to staff, working in tertiary clinics to deal with more challenging breastfeeding situations. So there is evidence that this is a valuable specialization that does have an important impact on breastfeeding.
Sorry, got to unmute. 4.2, the recommendation statement is to routinely implement the provisions of the Baby-Friendly Initiative and the World Health Organization's International Code of Marketing of Breast Milk Substitutes within the healthcare setting. And we should seek Baby-Friendly Initiative designation where applicable. So BFI is a global, structured, multifaceted breastfeeding program with system-level practice. And compared to standard care, it dramatically increases breastfeeding initiation, and it also increases the rates and length of any exclusive and continued breastfeeding. Next slide. So recommendation statement is to implement breastfeeding support in the workplace, including parental leaves of absence and accommodations for breastfeeding persons. So there's been a positive association between parental leaves of absence and breastfeeding intention, initiation, exclusivity, and continuation, where shorter parental leave negatively impacts any length of breastfeeding. So those who returned to work within 6 weeks of childbirth had the lowest breastfeeding rates and were less likely to continue to breastfeed upon return to work. So we're not just talking about moms who are quick to return to work, but also helping them once they return to work with them and supporting their decisions to breastfeed. So next slide.
We just wanted to point out some guideline appendices that we have that will provide more specialized information on some specific cases. For example, this table, strategies to support specific breastfeeding populations or situations, recognizes diversity in our breastfeeding population and provides some extra information for supporting breastfeeding persons with different backgrounds or experiences that may require specialized interventions or who might be dealing with specific problems with breastfeeding. So I would encourage you to check out the extra information and resources in this section. Next slide. We also have appendices on strategies to support specific breastfeeding populations, specific breastfeeding situations more related to the infant. So how to help support breastfeeding with infants with different clinical issues or different types of infants. So that we feel is a very valuable resource for everybody to have as well. Next slide, Stephanie.
Okay, so this table lists risk factors for delayed lactogenesis stage 2. So this can impact success with exclusivity and may increase risk of cessation and early introduction of formula. So this appendix was included so we can all be more aware of long-term and even short-term breastfeeding issues, so we can have the knowledge to support our clients reach their breastfeeding goals. So other guideline appendices that are included are the importance of breastfeeding to short and long-term health outcomes, clinical indications for use of formula, and strategies to promote and support exclusive and continued breastfeeding as the cultural norms. When I was going over the guidelines myself, I really appreciated these appendices and check them out, they're really good.
So in addition to the appendices, thanks Sonia and Stephanie, there is guideline evaluation measures, so this is specific to this guideline and as well as specific recommendations. If an organization is implementing this best practice guideline and wants to measure whether there is effective change in clinical practice and outcomes, then they can use these guideline evaluation measures as a way of indicating then success and where perhaps further change is indicated. Again, this is part of the guideline that we had stakeholder feedback in, and very helpful then to have that feedback so that we can validate these evaluation measures. So what next? So what do you do beyond reading this guideline, and how can we help you here at RNAO really to support you using this guideline to its full potential? So recognizing that at RNAO we develop these guidelines, we aim for an every 5-year guideline review to ensure the currency of the guideline using a rigorous development process. Beyond that, then, we want to support dissemination, so the spreading of this guideline. We do that in part through webinars and other conferences, poster presentations. We have a number of resources to support implementation and sustainability. So for organizations to actually be using this guideline to inform how they are providing care, how they are educating staff, what policies they're using that support and align with this best practice guideline. Additionally, as we've just discussed, then we create then evaluation metrics so that an organization can know then what impact using the guideline is having. And then if we look at that last level on impact then, so what impact is it having? Is it increasing breastfeeding initiation, exclusivity, and continuation? What impact is it having for us as providers? We saw in the evidence that when healthcare providers, nurses, members of the interprofessional team, and peers, when they were educating in breastfeeding, they were less regulating. We moved away from the every 3 hours, 20 minutes, that kind of mentality towards breastfeeding, but more one that was that trusted in breastfeeding, that was more of a baby-led and supporting the dyad. And then what changes can we see from the organization and the system? Do we see in Canada, for example, our rates of exclusivity increasing? Do we see improvement as far as less use of formula or other infant feeding products? Do we see overall increased continuation of breastfeeding? I just want to make you aware that we don't certainly just stop at the guideline. We really want to support organizations to be using it in their clinical practice and then be able to determine what impact it's having overall. In terms of supporting implementation, then, we encourage you to read the guideline, and we have the guideline available, as we say, in print form as well as online, and encourage you to read the full guideline. We've just done sort of a high-level overview today for you, but want you to have a read through each of the discussions of evidence, look at some of those supporting resources as well as the appendices. You can conduct a gap analysis. That's the process where you are doing a comparison of what does the guidelines say based on current available research from systematic reviews, and compare that to what current practice is in your organization or unit, and see if there is a difference, see if your practices are aligning with best practices, and if not, then where changes are indicated and what are those priorities. Our guidelines are also available as an app, as well as an online, the BPG mobile website. This guideline is just over 200 pages. The app is about 8 to 10 pages. So it's really saying, what does the person at the point of care, what would be the most helpful information and resources for them to have? So it's somewhat of a stripped-down version of the guideline that can be most useful when you're needing a quick look at the guideline. But again, we hope that you will read the full resource. We also have at RNAO our Best Practice Champions Network, which is a network of healthcare providers and other individuals who learn more about guideline implementation. What are the processes and steps that it takes in order to take a guideline, like the breastfeeding one, and implement it and use it within an organization. We also have a resource called Toolkit Implementation of Best Practice Guidelines that walks through the knowledge to action process that, again, supports the systematic and planned implementation of best practice guidelines. Lots of other resources that can be helpful for you. We also have a number of other best practice guidelines and resources that may be relevant to the breastfeeding population, recognizing while they have much in common, there also can be many other factors that influence their decisions regarding initiation, exclusivity, and continuation. And so I've just pulled a few. So our Integrating Tobacco Interventions into Daily Practice, released now last year, and does have a recommendation specific to pre- and postnatal women and their families. And it does have some discussion about the use of nicotine replacement therapy as a warning regarding the use of Champex in the breastfeeding population. So you can find that guideline online. It's also available as a print copy. We do also have, specific to pre- and postnatal women who are using tobacco and eLearn, and that's under that same website that we looked at for the breastfeeding eLearn, under the tab of mental health and addiction. And again, all of the e-learning courses are available to anyone. There is no cost for that. You don't have to be a member of RNAO. You don't have to be a nurse. Anyone can access that information. It just requires a download. In addition to the focus in pre- and postnatal women and tobacco, we made some other resources. We made a couple wallet cards in partnership with Mother Risk and the Smokers Helpline, one on pregnant women, one on I Am a New Mother, that includes a focus on breastfeeding. These resources are available on the tobacco-free RNAO website, and they are available as a free download. We also have print copies that you can order of them. The wallet cards are like the breastfeeding ones you found at Shoppers that sort of unfold in accordion style. We also have other resources on smoking after the birth, and also that discuss smoking with breastfeeding. We know that many persons will reduce or quit smoking during pregnancy, and unfortunately sometimes resume smoking in the postpartum period. So again, some resources on that, if that's of relevance to your population that you care for, and then some posters, and then we also made some information sheets on trauma as it relates to tobacco use, as well as stigma that persons may experience if they are pregnant and using tobacco. Other guidelines that may be of relevance here, a guideline that we released back in 2014, hard to believe, it's been that long, on safe sleep practices. This guideline promotes and supports breastfeeding as you would expect. It also has a recommendation that aligns with the current breastfeeding one on supporting informed decision-making regarding use of pacifiers and discussion as it relates to SIDS risk. The middle guideline there on crisis intervention for adults using a trauma-informed approach. We recognize that for persons who are considering breastfeeding, that a history of trauma could be something that influences their decisions. And so incorporating trauma-informed approaches to healthcare can be very helpful. As you may be aware, this isn't so much a focus on the trauma itself, but rather creating spaces that are safe, that are trustworthy, that involve empowerment and building strength and skills in individuals. Lastly, we have a guideline released in October now on perinatal depression that also includes a short focus on breastfeeding as well. And for that guideline, then, we had just a couple of weeks ago a similar webinar presentation, now available as a recorded presentation on the website. And again, the other image on the right side is just of the web page for that guideline. We'll be doing a presentation in January with the Toronto Breastfeeding BFI Network focusing on this guideline. Looking forward to that and hearing from nurses and other care providers in the Toronto area about the work they're doing in breastfeeding and how this guideline may be helpful to them. Any further questions, again, contact us on the RNAO website and as well my email address. We want to thank our funder, the Ontario Ministry of Health and Long-Term Care, for their support of RNAO's International Affairs Best Practice Guidelines program. And we will have, let's see, we're 12:50, so we've got a few minutes for some questions, if we have any. I'm just going to have a look in the chat box there. So Christina was asking, would it be helpful to do a prenatal referral to those pregnant mothers who are identified at risk for poor breastfeeding outcomes due to lack of education, previous exposure to breastfeeding experiences, role models in the family, previous bad experiences? And yes, I would link you to that recommendation 1.1 that focuses on assessment and assessment beginning prenatally to help identify those who may be at increased risk due to some of the factors you've listed here, just if they've had a previous poor experience with breastfeeding or challenges, or have a lack of role models in their family, maybe would benefit then from support from other peers. We know certainly that the peer influence, the role modeling, that really can positively impact breastfeeding, the initiation and continuation of breastfeeding. So certainly trying to identify that early prenatally can be very helpful to understand what someone's concerns can be regarding breastfeeding. Anything that Stephanie or Sonia you want to add to that in terms of the importance of role models, of being able to assess then prenatally breastfeeding intentions, plans, goals?
Yeah, I think that statement is, that comment points to a lot of the interventions that the literature shows are very effective. I think you are talking about boosting a mother's confidence, especially if mothers are at risk because of previous unsuccessful breastfeeding experiences. So for sure, you know, we need more than just telling mothers about the benefits of breastfeeding prenatally. A proper breastfeeding assessment prenatally really explores her ideas, her experiences, so that you can tailor your breastfeeding information and support to that.
And really, I think, thanks for that, Sonia, and also just reinforces in doing that then the importance of breastfeeding and recognizing that the breastfeeding discussion and plans starts during pregnancy, sometimes even preconceptually, and that persons may have ideas about what breastfeeding is or is not, and really can benefit from that earlier intervention. So Jody asks, I'm interested in seeing the items on the breastfeeding self-efficacy scale. Is this available without a journal subscription? So we include in the table some of the details regarding the breastfeeding self-efficacy scale. And do you want to add anything to that, Sonia?
Yeah, you know, the tool should be, the scale actually, although it was developed for research purposes, it's now being trialed as an assessment tool that we can use with all mothers, and then we would base our breastfeeding support based on their scoring of the items of that scale. So I don't believe it requires permission from the authors to use it clinically. And the idea is that the scale would be used clinically, I think maybe for research purposes, for collecting of data. But, you know, that's a really great question that we can clarify. I think we made the assumption that the items could be used, the scale could be used as a clinical tool.
Mm-hmm, mm-hmm. And I think certainly if someone was wanting to know more, they could contact the authors of that scale to see if they can use that scale with permission.
Yes, and you know, I'm thinking the way the latch tool is now widely used as a clinical tool. So I think the idea is the same thing for the breastfeeding self-efficacy scale, and I know that for Cindy Lee Dennis is very generous with, you know, use of her scale for research purposes.
Yeah, we certainly had good access to Cindy Lee and the tools that she has created, so it wasn't a concern for us. I'm wondering if there's other questions then, if anyone wants to put that into the chat box, just using the all participants option. That's helpful for us to see. Certainly from your comments, it certainly seems that some of these recommendations really resonate with you in terms of the value and the importance of breastfeeding education, as well as the involvement of the family and how the integration of the partner or the grandmother or any other family member that's important to this individual, that really can lead to the success of breastfeeding and helping someone to achieve their goals. And again, we appreciated the input from our stakeholders who really told us, again, how important breastfeeding was to them in their professional role and how they wanted for this resource to, this guideline, to have all of the important resources available.
So this is something I just want to reiterate to everybody, that this document really is a summary of all the recent literature and research evidence out there in terms of what we know makes a difference on exclusive breastfeeding rates and continued breastfeeding. So we hope that you share this widely with your colleagues, that you read it as well, and that we can develop some standardized, routinized approaches to breastfeeding support across Canada in terms of what can we do to really enhance our rates of breastfeeding exclusivity and longer-term duration to meet the World Health Organization goals of 6 months exclusivity and up to 2 years and beyond continued breastfeeding.
Thanks for that, Sonia. And Stephanie, does that also resonate for you?
Oh, absolutely. I know when I was going through the research, it helped to validate that what I've been doing in our community and what other midwives are doing is working. It's really nice to see it in the literature, and it helps, like Sonia was saying, it helps to standardize how we teach and what exactly we are teaching to our breastfeeding parents.
And so important, because we know that one concern that persons may identify with breastfeeding is the inconsistency in information, that the latch was really good with this person and yet another person looking at it sees something different. So that consistency in information really can help at a time when someone has a big learning curve as trying to successfully achieve breastfeeding. I see Christina's just asking, so if we go to the RNAO website, yes, you will be able to access the guideline. It's a free download, and any other tools. There are many links to many of the tools and resources. If you're having any struggles finding something, certainly just send me an email and I can help you with that.
There are like 100 links in this document. It's great.
Yeah.
And I found a little message there from Barbara Webster. Hi, Barb. I'm glad to hear you're there.
Okay, well, I'm not seeing any other questions. So if there aren't, I do want to thank everyone today for attending our webinar. And thanks especially to Sonia and to Stephanie for their involvement with this guideline. Again, a pleasure to work with both of them as well as all the members of our panel. And again, thanks to any of you who were a stakeholder as well. We have created a guideline, I think, that will be very helpful in clinical practice, and it is as a part of all of the hard work that all of you have done to contribute to this. So thanks everyone today. Thanks to Erica for helping us with this webinar, and to Sonia and to Stephanie, and on behalf of RNAO, we thank you for your attendance today.